Hello. Thank you for joining me today for a special webinar related to the routine screening of HIV, viral hepatitis, STIs, and latent tuberculosis toolkit. We are going to focus on the complex intersection between infectious diseases and substance use. Research shows that people who use drugs have an increased risk of infectious diseases combined with a lower utilization of primary care services. Adding infectious diseases screening to substance use clinics and substance use screening to community health clinics is a way to address this problem from both angles. I'm delighted today to introduce our guest, Dr. Sandra Springer. Dr. Springer is a professor of medicine in the Department of Internal Medicine, Section of Infectious Diseases at the Yale School of Medicine. She received her BA from Harvard College, her MD from the University of Massachusetts Medical School. She completed her internal medicine residency and infectious diseases fellowship at Yale School of Medicine. She is board certified in internal medicine, infectious diseases, and addiction medicine. She is also an attending physician at the Veterans Administration Connecticut Healthcare System and the director of the Infectious Disease Clinic at the Newington site of the VA in Connecticut. Her clinical research lab, InStride, which you'll hear about today, focuses on the integration of substance use and infectious diseases. She's an appointed member of the International Antiviral Society, USA, Antiretroviral Guidelines Panel for adults at risk and living with HIV, as well as an IAS USA core faculty member. She has been appointed to the National Academies of Sciences, Engineering, and Medicine's Committee on the Integration of Opioid and Infectious Disease Treatment and a member of the Academy's Framework for the Consideration of Chronic Conditions in Women. She is also a current member of the American Society of Addiction Medicine's Criminal Justice Guideline Committee and a former member of ASAM's Guidelines on Medication Treatment of Opioid Use Disorder. She has published over 200 manuscripts in peer-reviewed journals and has presented her work nationally and internationally. Now you see why I'm delighted she's here. She's truly a pioneer in this space. We are offering CME with this webinar. Make sure you're logged into your free EdHub account and click on the Take quiz to claim CME once the webinar has ended. I also want to invite you to join the chat. We'll be able to answer questions you have or guide you to resources that might be helpful. Without any more, I'll turn it over to Dr. Springer.
Thank you very much for that really kind introduction, and thank you all for listening today. So as you heard, I'm going to speak specifically about integrating substance use disorder identification and treatment and HIV hepatitis screening and treatment. Big topic, but important. So I'd like to start out with what we have in the United States, which is our Ending the HIV Epidemic Plan. This is put forth on the Department of Health and Human Service website, which is really getting to the what we'll be talking about is how are we going to implement this? One is in being able to diagnose people with HIV as early as possible. So that means to test everyone. And then immediately, if you test positive for HIV, being able to immediately offer antiretroviral therapy, including the same day as the test, and then to achieve viral suppression and maintain viral suppression. What's important about that is not only improving the morbidity of the individual, but also from a public health standpoint, we know that if individuals have a viral load that is suppressed, which is less than 200 copies per milliliter, they cannot transmit HIV to an uninfected person. So that is also really the important part of that. And then the third pillar is prevention. So if you have a test that's negative, being able to offer pre-exposure prophylaxis to prevent HIV, and also, as recommended by our Health and Human Services Department, is to provide syringe services for those who inject drugs. For HIV prevention, we now have 4 FDA-approved medications available to prevent HIV, including 2 oral regimens and 2 injectable medications, one including every 6 months to prevent HIV, and then being able to respond to the epidemic. So how are we doing with this? These are the latest data from the CDC. As you can see, it's lagging behind slightly, but we do have data for 2023, which may show a slight uptick. But overall, we've had a reduction in an HIV incidence in the United States. However, it's not really at the goal that we're supposed to. So by the end of last year of 2025, we were supposed to be down to 9,300 infections. And so we're really not at that level. When we look at the latest data, which is from 2023, put forth by the CDC about individuals who we know have HIV in the United States, again, this was put forth near the end of last year. Uh, we are a little bit behind our guideline, our what is recommended. So we'd like to see 100% of all individuals with HIV to have viral suppression, right? Right now, it's about 67% as of the end of 2023 have viral suppression. The numbers are slightly better in individuals who are enrolled in Ryan White Care clinic programs. But overall, we're not at that level. And there's disparities on many aspects, including race, ethnicity, sex, and also where you live in the United States at the reaching that particular goal. But importantly, as we'll be discussing today, is based on the transmission category. And among those who report injection drug use, both male and female, the levels of viral suppression are far, far lower than all other risk groups. So this idea of ongoing, which here is injection drug use, is a particular area that we should be focusing on. One of the recommendations is, right, to do HIV universal testing, but also assess HIV risk. And why is that important? If we do this universally, it also reduces the stigma and the potential bias, right? So if you incorporate that into your questions for everybody, you're less likely to miss an individual. But in general, people don't really readily disclose their sexual risk behaviors or potentially even ongoing substance use to healthcare providers just on their own without prompting. And we could go into a lot of reasons why that is. And also, it's important as we still see today that despite pre-exposure prophylaxis being available and knowing about HIV risk, that a lot of people are not aware of their potential risk or even aware of the prevention tools. So one of the recommendations is to ask, right? And ask in a non-punitive, um, you know, uh, 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 threatening manner, which we hope everybody is doing, but being able to offer something when you do ask these questions. So asking about sex, if they're having condomless sexual intercourse, without the use of condoms, if they're unknown status partners, even just one partner, and history of sexually transmitted infections, bacterial infections, gonorrhea, chlamydia, and syphilis, if they're aware when the last time that those occurred. And then, importantly, as we'll discuss, substance use. So not just injection drug use, but continued substance use. So there's a whole armamentarium here on treatment and prevention, and it's really at the status neutral approach. And the key is testing, right? So we have to test. We could go into a lot of potential algorithms on how to do that, but a simple HIV fourth generation P24 antigen antibody test, but also rapid HIV testing that you can do in your clinic or wherever you are to give that result. Right now, testing is you do not need to have the RNA test in order to start HIV prevention or HIV treatment necessarily, but you do need to get that test eventually. But that's where we get to the same day treatment and testing. And I will provide a reference from the CDC on what testing algorithms there are that will be available after this. But again, when you get to that first and second pillar that I was talking about earlier in the Ending the HIV Epidemic plan, what if you can give those results to a person in the moment where they are at the time that you're doing testing, obviously, then you can offer potentially treatment, not only for the individual, but as we said, to prevent HIV infections to uninfected individuals. And then from a prevention standpoint, there's a whole list of things we can help patients with. So if they don't have HIV, but they're at risk of acquiring HIV, if you could in that moment provide condoms, also discuss if you have them available in your community, certain services if they are injecting drugs, and substance use disorder as we'll talk, treatment as we'll talk about. And then of course, PrEP, as we discussed, HIV prevention. And then we can't forget about PEP, post-exposure prophylaxis. So somebody who might have had a recent risk and requires medications, and they do not have HIV right then, but should be offered medications to prevent HIV. And there also is a reference that I will be giving you about that. But currently, even one pill once a day of a combination of bictegravir, tenofovir, and emtricitabine, also known as Biktarvy, one pill once a day can be given for PEP, post-exposure prophylaxis, within 72 hours of exposure. So, and then there's transitions from PEP to PrEP. But anyways, the whole idea is we have a lot of tools, but in order for patients to know about them, we need to be asking, right, and doing the testing and providing this information. When we look at individuals who use drugs, as we're focusing this particular topic on, we are not doing a great job. Not only are we overall not doing a great job in the United States about providing PrEP or prevention tools to individuals who are at risk, we're in general doing even a worse job among populations who use drugs. So this is data from a study that was published in JAMA Network Open a couple years ago. It's not perfect, but the reason why I highlight it is it literally assessed how, if people were getting PrEP and only in this case, the one pill once a day, tenofovir emtricitabine pill, not the other forms of PrEP, among individuals who had a known opioid and or stimulant use disorder who did not have HIV. It was a large sample size, over 500,000 individuals. Again, these were individuals who were commercially insured, so not including those who are uninsured or those on Medicaid. So those populations even have a higher risk. But you can see that we only 1 in 500 persons were actually being prescribed this one version of PrEP. When we look at substance use and substance use disorders, they're quite prevalent in the United States, and probably this is underreporting, right? So this data is from SAMHSA and the National Surveys on Drug Use and Health, where people report if they use substances and then if they have a substance use disorder. So we know as of probably around 2024, this is still about the same. About 50 million individuals in the United States have a substance use disorder, and it's roughly half drug use disorder and half alcohol use disorder. But again, this is among individuals who are housed, not including unhoused criminal justice populations. So again, the numbers are probably much higher. And not just substance use disorders, but substance use, right? So you don't have to have a substance use disorder and be at risk. But I just wanted to just point out, I know this isn't about this topic of this presentation isn't about just substance use itself, but we have to remember that also asking about substance use in other settings, whether you're in an HIV setting or a sexual health setting or what have you, you could also prevent death through overdoses. So we know that opioids are the #1 cause of drug overdose deaths, mainly driven by synthetic opioids. It's not heroin, it's not methadone, it's not prescription opioids, it's synthetic opioids. And although there's been a slow downtick, it's still causing a significant amount of harm. So also not only asking about substance use to help in the HIV prevention, and as we'll discuss, hepatitis C treatment role, you can also potentially offer treatment to prevent death from overdose. Stimulants, a lot of people don't know this, but stimulants just on their own in isolation, about 40% can cause overdose themselves, but obviously in combination with other drugs is very prevalent. But we see a continued uptick in deaths related to cocaine and amphetamine type methamphetamine deaths. So it's also important to ask about that to get assistance. And we'll talk about that a little bit more. When we look at studies that have looked at the prevalence of substance use disorders in individuals who have known HIV, this is another study that was published a couple years ago. And again, just highlighting that individuals who have HIV are much more likely to have drug use disorders. And here, this is excluding cannabis use disorders. So this is really opioid and stimulant use disorder, and then a high prevalence of alcohol use disorder. And in blue are persons without HIV, and in gray are persons who have unknown status. So the numbers are probably much higher. This intersection of substance use and HIV is well known. We know for many, many years, right, ongoing substance use, in particular injection drug use, were associated with our HIV, earlier HIV outbreak in the 80s and 90s, and then we saw a reduction with methadone expansion, syringe services, and of course, antiretroviral therapy. But it was around the time of once the Scott County, Indiana outbreak occurred in 2015 that we started seeing a new wave of HIV outbreaks occurring among people who are using drugs, not just injection drug use. In Scott County, that, of course, as we remember, was related to a prescription opioid, a long-acting opioid called Opana or oxymorphone, also in a state where there had been a non-Medicaid expansion and a moratorium on methadone and a lack of syringe services. Again, so there was a lot going on. But after that, there were multiple outbreaks occurring in Medicaid and non-Medicaid expansion states from Massachusetts to Washington State, really where people related to heroin, fentanyl, and stimulants. And among individuals who were involved in the criminal justice system and unhoused and not getting access to treatment. And currently, right now, we have an outbreak you may know about in Maine, started about a couple years ago and is increasing currently among people who are injecting drugs and using drugs, but not just related to injection drug use, but really condomless sexual intercourse. Started up in the more rural area of Bangor and is now down into the Portland area. So still ongoing, and there's a lot that we have to do. And there's multiple other outbreaks that I haven't displayed here. Hepatitis C, as well as that, along that parallel of ongoing HIV outbreaks that were happening related to the earlier opioid epidemic. We also saw new acute hepatitis C outbreaks occurring, as you can see, among younger populations, really following that trajectory. And that then led to changes in our guidelines for testing hepatitis C. And before I go on to HIV further, I just want to highlight that hepatitis C testing and treatment is so critical, not only because of the number of individuals, and obviously it's not just substance use, but for everyone, because we have a cure. We actually can cure hepatitis C. You do not have to go to a liver specialist. You don't even need to go to an infectious disease specialist. An individual who is in a primary care setting, even a substance use disorder setting, you could actually provide medications that could cure hepatitis C. And that includes testing, obviously, first and foremost. So the antibody test is our rapid test. You could get in 15 minutes, get a rapid hepatitis C result. However, with hepatitis C, as you likely know, the antibody does not determine if you have the virus. You might have cleared that. So you need to get a hepatitis C viral load test. And then you can immediately give results to patients and treat them. There are some gaps in that, right? Because if you have to obtain the hepatitis C viral load, you may have a delay. There is now in the United States, as of the last couple of years, a rapid gene expert test available for some clinics and by Cepheid that you can get a viral load test immediately within 15 minutes and be able to tell somebody whether they have viral load detectable hepatitis C or not. And so that is now leading to really test and treat algorithms that are occurring. And then you could actually give the treatment that could cure hepatitis C, an 8 to 12 week potential treatment. I give you some guidance on that. So actually doing that in the moment, same day, like we would like to do for HIV. This is just, I'm not going to go through this, but this is guidance on how to do that in the initial appointment. And it also tells you which medications you could use without doing anything more, without the whole fibroscan and all that other stuff. Like you could test and treat, you're going to get all these other labs and assess hepatitis B status and all this other stuff. But you actually, there is a welcomed guidance that is put forth on doing rapid treatment. I did want to highlight a couple of things about this integration, as I'm going to get to, and I focused my pretty much my whole career on this. It's just not just me that's saying this. There's the Department of Health and Human Services several years ago tasked the National Academies of Science and Engineering Medicine to put a group together to really identify how to better integrate responses. And this was originally just the opioid epidemic, but include other stimulant epidemics and infectious disease recommendations for HIV, hepatitis C, and others. And this study occurred across the country and was published, and it's available to you to review. And I won't go into all the details, but I did want to highlight, I was part of this committee. We used the SAMHSA's standard framework for levels of integrated healthcare to utilize to compare programs across the country that might be integrated, and how to improve HIV, substance use disorder, and other infectious diseases. And if you refer to that, you'll see, you probably are aware there's different elements of integrated care. The first is like very minimal collaboration, at a distance. And then there's the co-located um, uh, maybe services that you might have in your clinics. They have separate systems. You might refer to somebody. And then there's really the integrated programs where you have somebody on site with this expertise in infectious disease and substance use disorder, maybe actually in your clinic, so you don't have to refer somebody, or you yourself could be, have both care. So not to belabor all of this, and I encourage everybody to read the full report. Came out at a very tough time in January of 2020, if people remember. But there were some things that were key that came from all of these reviews of these different clinics across the country, which was really, if you wanted to integrate care, having a clear plan across your institution, getting buy-in from key stakeholders, having a multidisciplinary group, which includes persons with lived experience, partnerships inside and outside the healthcare system, really identifying barriers to care. So if you are doing this test, treat algorithm and integrated care, are they able to follow up? Do they have transportation barriers, housing barriers? Really looking at different entry points that may include urgent care. Do you have certain hours, telemedicine, mobile health, and also really key data metrics so you can follow changes over time and really invest in communication. And this is across places. We saw lots of problems, right, from substance use disorder programs to infectious disease and hospital systems, that there was this lack of electronic data system sharing, and really trying to improve upon that. A summary of these guidelines was published in JAMA a couple months later, and I encourage you to look at those. But these recommendations were given to the Department of Health and Human Services and SAMHSA, and they actually did make some changes, one of which is, you're probably aware of, the removal of the X waiver, which came forth from these guidelines. So there's a lot of things that did happen. I also put this reference up if you're looking for other care models that have integrated HIV and substance use disorder. I won't go into it, but there's tables and showing you some programs maybe that are in your area that have been able to do that successfully. When you're thinking about integrating care, though, you have to ask, right, as we just talked about HIV, hepatitis C testing. So you may have a substance use disorder program. So how would you integrate HIV and hepatitis C testing? Or you might have an infectious disease or primary care setting, and you want to integrate these. So obviously it's screening and diagnosing. This is called measurement-based care. So you do a test, right? Are you going to be able to follow up with those results and provide guidance to a patient? So if then we always talk about this in medicine, right? If you're going to test and you're going to ask something, do you know what you're going to do when you get that result? And be able to provide care, so the medications or behavioral health or what have you, and then help retain in care. For substance use disorder, I'm not going to talk about all of these measures, but these are some that are approved for screening and also diagnosis of substance use disorders. The TAPS, the first one, is put forth by NIDA. You could integrate these in your electronic health record system. You could have, people do these while they're waiting in the waiting room if you wanted to. There's a couple that we developed that are validated for the DSM-5 opioid and stimulant use disorders for non-clinicians to administer in less than 5 minutes to get a diagnosis. And then that could lead to treatment. And then, of course, alcohol use disorder, the audit. So those are just some tools. Why is that important? Obviously, for opioid use disorder, if you identify it, you could potentially uh, reduce harm, overdose by being able to identify people who could get treatment. And we have 3 FDA-approved treatments in the United States, 2 of which you can provide in non-licensed opioid treatment programs. So in a primary care setting, HIV care setting, hepatitis C care setting, you could provide buprenorphine or extended release naltrexone. And then methadone, of course, in this country has to be provided only for opioid use disorder in a licensed OTP. But all have been found to reduce use, reduce overdose, and importantly, reduce HIV and hepatitis C risk behaviors, and also help with treatment of HIV, viral suppression, and cure of hepatitis C by co-integrating care. And don't have time to go into that, but there's lots of evidence for that. I'm just giving you a couple of guidelines. If you are interested in treatment for opioid use disorder, we have the American Society of Addiction Medicine guidelines and also a free resource that you can look up on PCSS, Providers Clinical Support System here. Alcohol use disorder, we have 4 FDA-approved medications for alcohol use disorder in this country. The most effective have been the naltrexone, oral and long-acting injectable medications that can reduce craving and alcohol use. Although not perfect, they do help in many instances. But it's part for alcohol use disorder, it includes also behavioral treatment components, including 12-step self-help programs. And that abstinence is not necessarily always the right outcome for everyone. And there's evidence to show that if you can help a person get to low risk drinking, that can have improved not just alcohol use disorder outcomes, but also HIV outcomes and other outcomes, including reducing cancer risk. The key thing about alcohol use disorder that I always recommend is just reminding individuals that, it might be great that you identify and somebody's interested in treatment and wants to stop, which is awesome, but you have to just make sure they don't have a risk of alcohol withdrawal, because if they do and develop severe alcohol withdrawal symptoms, they could potentially die. So understanding the history of their prior treatment, and if they have never stopped drinking, that would be a person I would first probably recommend for inpatient detoxification prior to treatment. And here are some guidelines and recommendations from authorities on this, including National Institute on Alcohol Abuse and Alcoholism and SAMHSA and ASAM. Stimulant use disorder, as we said, is a huge problem. Unfortunately, we don't have any FDA-approved medications for it. However, contingency management, a voucher incentive-based program has the most efficacy in helping patients reduce stimulant use, and also has been found to improve HIV outcomes as well as hepatitis C outcomes. Unfortunately, the big problem is across our country, we don't have a lot of programs that include contingency management, and so many people are not getting access to this. I did want to point out a really good resource that came out in January of 2025 from SAMHSA, is how to implement contingency management-based programs, and also potentially to get payment insurance also to pay for these programs too. This is just also another example. There's been a lot of mobile technology, telephone apps used to kind of help for many things, but in particular substance use disorders, and one of which on this topic of contingency management, I'm just putting here to give you an example. It is available to recommend for patients. Some states might have this even covered for insurance. But it's called Dynamic Care, and it actually provides an individualized contingency management for the person whenever they need it, with abstinence-based kind of guidance and incentivization with saliva-based testing. And then I also wanted to give you this reference from the ASAM and AAAP, which is awesome. It's for stimulant use disorder, and although there's no FDA approved medications yet, this group actually put together tables of medications that potentially you could use for cocaine use disorder, amphetamine type use disorders with co-occurring conditions, side effects, and things you might want to monitor in addition to the behavioral based programs. So it is a really good resource and it's free. And just to say all of this, that, for HIV, is the area that I've focused a lot of my work on, that if you do treat substance use disorder, you can actually improve this other distal outcome, which is HIV viral suppression, which is part of, our goal, which is our main goal for HIV because we don't have a cure. And we did a lot of those studies early on, including with buprenorphine and extended release naltrexone, both for opioid and alcohol use disorder, including double-blind placebo-controlled trials that showed among people with HIV that continue, if you could identify those opioid or alcohol use disorder, give them medication, especially for this particular area that I work on, criminal legal populations before they get released, you can improve the likelihood of achieving and maintaining viral suppression. So this idea of treatment of substance use disorder with HIV is treatment as prevention. There's also been some evidence of contingency management programs also improving HIV viral suppression. And there's a recent study that was just published I think it was just this past year, on an HIV integrated care program with contingency management that improved HIV viral suppression by Aisha Appa, APPA. In addition to all of this, we have other recommendations, right, that I referred to earlier on, which is we should be not only assessing substance use, because you can also help provide naloxone. We have the intranasal as well as injection options, but intranasal is the one that's most commonly used. And other things on how to train family members, loved ones on how to recognize overdose. Testing strips recommended by the CDC if people can test their drugs for fentanyl. Also, xylazine, providing vaccinations, and wound care supplies are also very important. And my last thing, if you remember those three stages, I was saying is it's really incumbent on us not just to initiate and identify HIV and hepatitis C and substance use disorders and potentially start treatment if we can. It's also thinking about how you're going to help people retain and care and overcome some of those barriers. And a lot of our population have transportation issues, housing instability, poverty, may or may not have insurance, right? Lack of communication. Many of my patients don't have cell phones. If you don't have a cell phone, how are you going to get appointment reminders and other things? A form of ID. A lot of my patients don't have that. So helping people get that, and you really need that in a lot of places. Not some pharmacies require an ID, some obviously methadone programs. Obviously, we just talked about substance use, co-occurring mental illness, pharmacies, another area that I work with. Just remember the same barriers that we see in our healthcare settings can be the same for pharmacies, maybe not even finding one in your area. A lot of copays, stigma is a major issue. And a lot of pharmacies don't actually carry the medications you want them to take, including HIV medications, PrEP, and opioid use disorder treatment. So it's on us to kind of figure out what pharmacies do carry the medications we want our patients to take. And really just stigma, of course, is a major concern of infectious disease and substance use. And then this just can be quite overwhelming. So having somebody that can help navigate these barriers is really critical. So we've been working on providing healthcare and bringing it to where people are. And one of the solutions is, although it's not a complete solution, is legalizing pharmacies to become mobile, associated with clinical care and community healthcare worker care, which is what we've done in Connecticut. It's a model. It's not going to be perfect for everyone, but really having the medications available when you want to prescribe them in whole person healthcare, not assuming you know. So being able to do the HIV testing, substance use disorder, but also blood pressure checks and diabetes checks and vaccinations. And this is something we've been doing for the last couple of years, just, really trying to reach populations that might not be able to access traditional healthcare systems or want to, actually. And really a diverse population that we've been seeing. And just pointing out the number of prescriptions that we're dispensing, and it's not just specifically in very low likelihood of HIV PrEP. It's work that has to continue to go. People are really PrEP is really lower on their list, and it's our job to kind of help people understand and get people onto treatment. But high blood pressure and some of the primary care needs are really huge. This is some older data, but we're finding people out of care. So, and we can provide rapid testing and in the moment antiretroviral therapy and PrEP. Um, and we picked up 4 new diagnoses and able to not only get them into treatment, but also link them to care and hepatitis C also. So being able to test and actually for some people, the first time ever they've been offered curable hepatitis C treatment and being able to leave from that pharmacy getting dispensed curable hepatitis C treatment has been really wonderful. I'm going to leave you with a couple other guidelines that I think are really important. The Department of Health and Human Service guidelines on the use of antiretroviral therapy treatment for people with HIV. It's really quite detailed, including substance use disorder, HIV, hepatitis C, STIs, and really good recommendations. And then the International AIDS Society USA guidelines, which also give kind of real world recommendations on HIV and also substance use disorder treatment. I'm a part of that guideline and really happy that they included substance use disorder treatment. And then I'm going to leave you also with this. This is a also free website. If you're probably aware that although we removed the X waiver, there is just one thing you have to do if you have a controlled substance license is to do a one-time 8-hour medication access and training. There's many places that offer this, but this is specific for if you're interested in HIV and substance use disorder, and you can go online and everything is there in the slides and all of that. This is a national substance use warm line. I put it in my phone. I don't often use it, but I give it to people that you can actually call and talk to somebody, a clinician to a clinician, to talk about addiction medicine and HIV care. And I just show you this. This is out of San Francisco. And I'll just leave you with some final thoughts that really aligning the needs of people, identifying you have to ask, right, in a non-punitive way about HIV, hepatitis C, and substance use. Not one size is going to fit everybody, but really keeping this in a universal kind of status neutral approach, non-judgmental, and then figuring out what your people, your community, your patients need, and trying to come together to help align their needs and hopefully maybe make some changes in your programs so that you can incorporate some of these things. Just wanted to thank a whole bunch of people, including my InStride research team and all the folks at NIH, NIDA who funded our work, and a lot of government officials in Connecticut. And I will end there and hope to answer any questions and really thank you for your attention and thank the organizers for this having me here and having this topic discussed. Thank you.
Thanks, Dr. Springer. This has been super insightful. I made so many notes here in front of myself to bring back to my own system. But I do have I think a couple questions. One question I have is on the InStride van that you have, what types of healthcare professionals are on the van? Is it just a pharmacist, a physician, a community health worker? Who sort of staffs that when it's out?
Yeah, great. It's a great question. So one half of it is a retail pharmacy, just like a CVS or Walgreens on wheels. So there's a pharmacist with the pharmacy. And then the other half is a clinic, and it's staffed with a family certified APRN who can prescribe and see patients for primary care and specialty needs for all ages. And then there's also on the unit a medical technician who can perform phlebotomy and do social needs, financial navigation, help with insurance, register you. And then what I call that's called the mobile hub. And then the mobile spokes include community healthcare workers who are trained to go out into the community, so we don't assume that people are just going to come up to the unit, but can go out and can do on their own rapid HIV, Hep C testing, blood pressure
Mm.
checks, finger blood glucose sticks, social needs, and either help link them to the mobile hub, the pharmacy and clinic, or to the surrounding brick and mortar services. So it's kind of a team approach. Yeah.
Yeah, it's like sort of like you mentioned, understanding the syndemics of the infectious diseases of the community of what your people need is going
Right.
to help you understand how to best, meet those needs.
Right.
I've got another question. So this program is obviously phenomenal. For those of us who maybe are ready to start the mobile clinic but don't quite have it off the ground yet, what's a good place for us to start? We're motivated to do something, but we're just one person. Sort of what do you recommend as step one?
Yeah. So it's a great question. So the way I think about it, I think about it myself. So the way I started, we had a couple of mobile health units without the mobile pharmacy. And the reason why we did that is because I was identifying that all my patients weren't coming into the clinics. We were seeing like huge gaps. People couldn't get in there. So providing a mobile health unit, going to where people might want to be and providing care. And then I found out, oh, I could provide all the care I want, but they weren't getting access to the medications. So then I was like, oh, we have to be able to figure out how we can bring a pharmacy to patients. So I think the first question is, we have a lot of your clinic. If you have a Ryan White Care Clinic or substance use, you might have case managers or individuals who are in the clinic themselves. But I think it's first taking a step back and saying, are you really reaching populations? Are there populations that potentially can't access you? Are there ways in which maybe you have case managers who could go out into the community to identify where those needs are? Um, and so I think the first and foremost is what is your need? Maybe everybody is coming to your clinic. Maybe that's not the issue. And then the big problem is people are having a hard time retaining or getting access to medications. So the first question I ask is what is it that you are determining could be a potential gap? And then it might not be all of this. Maybe people have no problems getting access to medications. It's just that they can't, I don't know, get their blood work or something. So then it's figuring out what is the gap and then providing that. It could be a visiting nurse. It could be a home-based program. It could be a pharmacy delivery service. And a lot of us have like some mobile unit during COVID. We kind of had, people going out and doing things. So there might be something that's available to you, like even a car or a unit, or it just could be people individually going out, what we call street medicine, or visiting nurses, like I said. So I think that one question is um, especially if you're in an academic healthcare setting, you have a lot of people around you, but is there somebody who's really understanding and evaluating the people and the data and understanding, oh yeah, we started so many people on treatment, but hey, we're seeing about 30% aren't coming back. So what is going on with that 30% of
Mhm.
population, and how are you going to identify them and help that population? So that's just one example.
No, that's great. I think sometimes, at least for myself, I get so excited to sort of do something and get in there that it's a good reminder to take a step back and do the needs assessment and figure out, everybody has limited time, everybody has limited resources. So where do you need to spend those two things? What does your community need?
Right.
What do your patients need first? And then working to fit what you can do into those gaps. So that's great advice for us all. Thank you. So thank you, and thanks again to our audience for joining us today. Thank you for being here and spending time with us as we look at how to improve screening for infectious diseases in people who use drugs. Please check out the Routine Screening Toolkit to help you wherever you are in implementing or improving your screening programs. We have the QR code on the screen as well as the website address for you to check out. I encourage you to look through there. There's a lot of really great resources. As a reminder, we have free CME available for today's activity. The webinar will also be available as a video on demand for you to rewatch or share with your colleagues. Have a great, great day.